Our next speaker is Dr. Rakesh Venturimilli, is a distinguished anesthesiologist and critical care expert, actively involved in prestigious uh, societies like ISA, ISCCM, and ECMO Society, and is also a dedicated teacher and a speaker in national and international conferences. And with his remarkable record of safely airlifting over 100 ECMO patients, he is committed to advancing high-end critical care services in India. His initiatives focus on public and doctor awareness, promoting economical ECMO access, and fostering indigenous medical equipment development. Driven by passion for innovation, he strives to make advanced healthcare affordable and accessible. Over to you, sir, Dr. Rakesh Venturimeli.
Hi everyone, I'm Dr. Rakesh V from Hyderabad. So I'd like to thank the organizing committee for ELSACon 2025 for giving me this opportunity. So next few minutes, I'm going to talk regarding the preparation for ECMO. So when you're going to initiate an ECMO, whether it's an in-house program or whether it's an outreach program, so how you are going to prepare yourself for a safer ECMO outcomes is the talk which I'm going to talk in the next few minutes. So I'm Dr. Rakesh V from Hyderabad, around 10 years of experience in ECMO and critical care. So I'd like to go by presenting this slide initially here. You can see two different characters on the screen here. The one who knows to fight very much good, but he does not know the exit strategy. You can see Abhimanyu on your left. So he knows how to fight, he knows how to enter the Padma Vyuham, but he does not know how to come out. So if he does not know how to come out, again the chances, so he failed as a warrior. So he died in the war. And the other side you can see Lord Krishna, wherein he is prepared for all the complications which he anticipated or which he is not anticipated to. So you can see from both of them that you can learn from both of them that preparation is always key to getting a success here. Okay, so without wasting much time, we'd like to go ahead and see what you're going to learn here. So it's an in-house ECMO initiation. So let us see. So you have a separate topic, how you're going to prepare the patient, like the positioning of the patient and all separate. I'm going to talk predominantly on the non-patient related issues, how you want to initiate ECMO, especially when it's an in-house program. So I predominantly divided this talk into preparing the family, preparation of your medical team or manpower, and preparation of your logistics inside your ICU here. Of all the preparations, the most important thing is the family preparations, because if you are not able to prepare the family properly, you might land up in a lot many issues in the later date. The most important step in preparing or initiating ECMO at any place, whether it's in-house or outreach programs or anywhere, is like preparation of the family here. So you need to counsel them properly on what the family is supposed to understand when it comes to ECMO. So they need to understand the present situation of the patient, like what's the situation of the patient, how much you have tried him to get back to life or get back to his normalcy by using different modalities inside of critical care. Some basic physiology of ventilator, why it is not working for him, because his lungs are getting bad. The ventilator is unable to help him beyond a point of time, beyond a point of care here. So they need to understand how your ventilator works and how your ECMO machine is going to work here. Estimated duration is the most important thing. If you don't prepare the family for the duration part, you might end up in a soup. And you have to prepare them for the outcomes also. ECMO is not a magical treatment. At the same time, it's not a treatment per se. They need to understand ECMO is just a support till the lung recovers. So they need to understand the proper outcomes and statistics. You can show them some statistics from ELSO. You can show them statistics of your local center. You can show them the statistics of ECMO Society of India, so that they can understand what is actually ECMO is and how much you can expect from the patient's side. And they need to know the finances involved, especially in a subset of population like Indian populations. So definitely they need to understand what kind of finance, how much is the finances that is going to be involved in the whole ECMO run for the patients. And ultimately, as I said prior, exit strategy. Without exit strategy, you might end up in a war dead, like Abhimanyu. So you need to have proper exit strategy that should be planned, that should be discussed with the family also prior. Like how many days you're going to try for these. Sometimes the family might ask you, sir, how many days it's going to take and how many days you're going to plan. So you need to have proper exit strategy, whether the exit strategy for recovery, whether it's exit strategy for transplant, whether it's exit strategy for a comfort care or a DNR kind of a thing. So you need to plan it prior. So without a proper exit strategy, don't try to enter into your ECMO here. And always, while counseling the family, console them and also give them an option of going for second opinion. If they go for a second opinion, their doubts will also get cleared it off. So once you meet an ECMO physician or an intensivist who is working, who is not at all related to your hospital, if he gives the same opinion as you said that now there is no other option left except for the ECMO, the family will also be consoled and they can easily accept the patient going on for the ECMO here. The next step is once the family is ready, you need to prepare a team. So you have to divide the team into different subsets. Each subset will take care of one job in particular. So you can see I have divided my team as a counseling team who predominantly counsels the patient attenders, makes them understand the situation, what I'm going to do, and what I'm planning to do on their patients. Procedure team. So these are the actual members who are going to do the procedure, and then a non-procedure team, we can call them as a helping team, which is also equally important for a successful ECMO run or for successful ECMO initiation. And out of all these things, you need to have a proper team lead who has to coordinate between all these things. So if you can see the team lead, the job of a team lead is coordinating with all the subsets of the teams, identifying the major issues and the problems in the patients, and then correcting it as soon as possible. Taking care of the patient's vitals, that is one more team. So one team is again given for taking care of the vitals, for infusion of drugs, taking care of vitals. So you need to dedicate two members at least. One goes for the head hand and one goes for infusion or giving up of the drugs or the management of the drugs part. And one team for the cannulation. Generally, we say around 4 members is required. Two for femoral and two for jugular are required. And another team for circuit priming. So at least 2 members for the circuit priming. If you can see this video, there is a team here who is planning for the cannulation. There is a doctor with a stethoscope on the head and taking care of the vitals. There is one more guy, if you can see, he is trying to infuse the drugs on the left side. Yeah, you can see this one is trying to hold the echo probe and try to infuse the drugs also for this patient. This is how you are supposed to divide the team here. The same thing here. So I'm cannulating this patient on the femoral end. The femoral end cannulation is done. And then we went on for jugular cannulations. And the guy on the left is giving some drugs like calcium gluconate and soda bicarb as and when required, the sedation part also. And you can see a perfusion team on the blue dress who are trying to perfuse the ECMO circuit on the extreme right corner. So these are the basic team members. You have to divide the roles of the team members, what team member is doing in what, and there should be a proper team lead who is going to coordinate the things always. So you have done the financial counseling, you have done the patient preparation, and then the procedure team, and you need to have a proper helping team like the non-procedure team also in your team. So which includes a bedside nurse. So she should be loading all the drugs. So she should be handing over all the syringes. She should be handing over the drugs, whatever is required at that point of time. You have to prepare the patient places where your femorals, especially femoral place, the groin preparation and positioning of the patient, like keeping the wedges under their hip joints, keeping the wedges under their shoulders is much more important. And she has to take care of a proper checklist. So you need to have a checklist for initiation. So whether the checklist has been completely cleared or not, the non-procedure team has to take care. And she should also take care of the quality control, how sterile way you are going to place this patient on ECMO. And don't forget, you need to have a surgeon in your helping team also. If it is a VV ECMO or VA ECMO, initiation is fine with an intensivist cannulating both vessels, artery and then the vein. But sometimes you might land up in situations like hematomas. If the vessels are too narrow, you need to have a surgeon on the bedside, or at least you need to have a surgeon on a phone call who can come and rush for your help. So it might be a vascular surgeon, a CTVS surgeon, or it might be a general surgeon. Whoever it is, try to keep the surgeon in your helping team here. And the most important thing again, you need to have a blood bank officer also in the same helping team. Once the code ECMO has been initiated, this blood bank medical officer should also come into place because we might require multiple blood products transfusion during initiation and maybe after initiation too. So these are the various team members in your non-procedure team. The blood bank medical officer is one. And the last important thing which we need to manage is going to be the logistics part. So if you can see the photo on your left side, you can see one patient on a bed and you can see all the monitors there. There's a ventilator, there are infusion pumps, there's so many monitors. So you can easily identify that one ECMO patient consumes two bed spaces in your ICU. So whenever you say or whenever you inform your team that we are going to initiate ECMO for this patient, make sure you're dedicating 2 ICU bed spaces for that patient. So why you need 2 bed spaces? Yes, okay, we can see in the photo also itself that the ventilator is taking a lot of space, the syringe pump, so there's an ECMO machine on the right side, It comes with a blender and a heater cooler unit, and you need to have an ultrasound and 2D echo always on the bedside. So all these things will consume a lot of space on the ECMO patient's bedside. You cannot have a congested bed space with an ECMO patient. So you need to dedicate at least two bed spaces is one important thing. All these machines which you are seeing here is mandatory before initiating an ECMO. You need to have an ECMO machine, you need to have heater cooler, blender, and everything here. So coming to the again the logistics part, next thing is to make sure that your team has made sure the initiation kit ready. So what does an initiation kit contains? It contains of an insertion needle, just like a central line, but only thing is the guide wire is the lengthier guide wire when it comes to ECMO, and the dilators will have different sizes of dilators starting from 18 gauge to 24, 26 gauge is available here. It consists of an insertion needle, it consists of a guide wire, extra stiff guide wire of at least 150 to 200 centimeters length. You need to have dilators of different sizes. You need to have a PLS circuit, and you need to have suture materials for fixation of all these cannulas. So these things are also kept ready on the bedside, and even the ACT machine. So you can see an ACT machine on the ECMO console here. So the ACT machine should also be kept ready here. And one more important thing which I'll always emphasize for all my ECMO patients is dedicating a crash cart, especially for the ECMO. We call it as an ECMO crash cart. And let's see what does it contains. It contains of an extra cannulas. So you need to have one venous and one arterial cannula for initiating ECMO in your in-house program, and you need to have extra connectors. So in case if you are converting a VV ECMO to VAV ECMO or VVA ECMO, suddenly if there is a cardiac arrest, you have to convert VV to VA ECMO. So you need to have an extra connectors. You need to have extra cannulas also. Don't try to forget extra connectors and extra cannulas in your crash cart. Sometimes an extra circuit length is also required if some circuits from different companies are of shorter length. So in those situations, proning is going to be difficult, transport is going to be difficult. So you need to add extra circuit length. This also should be incorporated into the crash cart. Extra oxygenator, especially when you're cannulating a pulmonary thromboembolism case or a case with a high pulmonary or any thrombus burden, which is pretty much high. Your oxygenator might be flooded with clots with the initiation itself. So you need to have an extra oxygenator always on the bedside while you're going for initiation of an ECMO. An extra circuit. So both of them are technically the same, whether it's extra oxygenator and extra circuit. You need to keep that in an ECMO crash cart. And the insertion kit. Sometimes the guide wires might fall down, the needle might fall down. So you need to have an extra insertion kit. So this is the concept of an extra ECMO crash cart, which should be there on the bedside. If it's an in-house program, you have to create this crash cart by yourself and keep it ready on the bedside. You have to inform your team before the time you arrive there. They should keep all these things ready. So this is how you prepare yourself when you're going to initiate for an in-hospital ECMO initiations. Coming to the outreach, like out of hospital ECMO initiations. So most of the centers or most of the hospitals now they're doing these outreach ECMO initiation programs. Even there are separate teams which are doing it. So in the outreach program, you can broadly divide them into initiation part and then the management part. So the teams will initiate a patient on ECMO at a remote place and try to manage it to a telemedicine kind of a thing. It's like they'll give the orders remotely and then it will be managed by the local team there. The other approach is remote initiation, and once the initiation is done, transferring the patient to your center. So let us see each thing differently here. Remote initiation and management at the same center. So in a remote initiation and management at the same center, as an ECMO physician or ECMO team lead, you need to understand the hospital where you're going. So what kind of hospital it is, whether it's a tertiary care hospital or secondary care hospital, what facilities it is going to host us, and equipment, whether the ECMO machine is ready with them or not. Otherwise, you have to take your own ECMO machine and circuit. And you need to have basic ultrasound machine for puncturing. You need to have 2D ECMO machine to see the guide wire positioning, and then you might have to see the tamponade which is going to develop. You need to have basic chest X-ray machine and ABG machine. Of course, these are basics, but still you need to find out whether the hospital which is having a patient where you're going to initiate ECMO has these equipments or not. And ACT machines, so once the guide is in, you need to have an ACT machine in place. Multi-para monitor with invasive blood pressure monitoring is mandatory, which I generally advocate to all my ECMO patients here. And it should have a blood bank. If blood bank is not there, make sure you get all the blood products ready prior before you're going for initiation of your ECMO. And the most important thing is how much distance is that hospital. So if I'm going to initiate a patient on ECMO in a remote center, how much distance is this from my place? Because time is always that thing. Time is always that matters. So if it is for example, a patient is in a cardiogenic shock and it takes at least 2 hours for me to reach that place, So there is no point in that. The patient is not going to wait for you for 12 hours to reach there and then go for initiation of ECMO. If it is a VV ECMO or it is a ARDS patient, yes, he might give us some time so that he can reach there and all. If it is going to be a cardiogenic shock or a LV stunning kind of a scenario, this patient cannot wait for 6 hours or 8 hours at least for you to reach the third place. So you need to understand the distance and the way of approach you're going to go to that hospital. So if it's going to take a long time for you, and if the patient requirement is a VA ECMO especially, you need to find out an alternate source who are there nearby for the initiation part. If your hospital cannot do that, and then try to manage the patient. Facilities. So as I'm talking about the facilities, so sometimes you have to initiate ECMO in the ward, sometimes you have to initiate the ECMO in high dependency unit. Most of the times after the COVID scenario has gone, so we are initiating the ECMO in the ICUs itself. So as I said, what kind of facilities where you're going to initiate is much more important here, and who is treating that particular patient. So there are a lot many states where these ICU patients are being treated by quacks. I'm not going to say anything about those states, but you need to understand if it is properly treated by a qualified personnel, then you can judge the requirement of ECMO for that patients here. So understand whether the patient is treated by a qualified personnel or not. Understand whether the blood bank availability is there or not. You need to understand the availability of surgeon too. For example, if you went to a different remote location and you started initiating and then there's a huge hematoma that is uncontrollable, so you need to have a surgeon's availability also. You should make sure that the team which is there on the remote location, they have contacted the surgeon, keep him in loop. So that's also much important, pretty much important here. As I said, again, the two bed spaces, that institute might not know that because it's not a routine ECMO practice for them. So you are going there and initiate. So you need to tell them that I need at least two bed spaces for this ECMO patient and nursing support. So what kind of nursing support they can provide is also important in the outcomes part here. So the most important thing, once you have done everything, what are the prerequisites which are required? So before you go to a particular place and initiate the ECMO there and manage, so you need to talk to the treating doctor. So whoever is a treating doctor, you need to talk to the treating doctor before you start from your place. There are several instances where the initiation team has started from the place without knowing any history. They just got a call from a particular place saying that my patient is not improving on a ventilator. You need to come and initiate the ECMO. So before going to that particular place, try to talk to the treating doctor because most of the times it's going to be false alarms. They might not have ventilated the patient properly and they might have counseled the patient directly for ECMO. So you need to understand that. So always talk to the treating doctor. As I say, it's always a prerequisite. Counseling by the primary team or the treating team which is there prior to your landing or prior to your starting itself. The minute you land there, the patient attenders might say, so I am not being counseled, I need much more time. So to avoid these kind of delays, no, the primary team or treating team at the remote location, they have to counsel the patients because already they're treating the patients in the last 7 days or 8 days or whatever it may be prior to your starting or prior to your landing in that particular place. So you need to have a checklist for that, and that should be sent to the particular center or the particular treating doctor so that they'll arrange all the logistics by the time you arrive. The most important thing which you generally miss is blood products reserve and the equipment which you have discussed. All the equipment which I have discussed, like the machines, the circuits, the logistics part, like the connectors, dilators, the insertion, everything should be checked and it should be included in a checklist for initiation of ECMO. So that's how you need to prepare yourself. You're going to have a remote initiation and management there particularly. If you don't have a proper personnel there managing the patient, you cannot manage the patient remotely also. Coming to the second scenario here, in a remote ECMO initiation and transferring to your center. So you need to understand that you are also involved in the transport of that particular patient. So you need to arrange so many things for the transport part also. So initiation part, once discussing with the treating doctor, discussing with the family, making the family understand the need for ECMO and all those things, the initiation part is almost the same here. Checklist. So you have to send the checklist again to the particular center. The center will make sure the checklist has been completely checked and then the equipment has been completely present by the time you arrive only. The distance, as I said, the same thing is here. Permissions. The only thing is permissions for landing the air ambulance. Whether the air transfer, you are planning to transfer to your center. So you need to plan prior itself that how you are going to transport that patient after ECMO to your center, whether it's going to be an aerial route or whether it's going to be a ground route you're going to transport. So you need to plan accordingly. If it is an aerial route, the procedure is different. If it is a ground route, the procedure is different here. So it all matters upon the distance, the finances, the understanding capability of the attenders, and then the clinical condition of the patient too. If the patient is critically ill, you cannot have a long distance transport taking too much of time here. And if it is an air transport, you need to take all the permissions for air ambulance landings, certificates from both the hospitals saying that this patient is treated in the remote center and this patient is being shifted to our hospital. Like that, you need to have the certificates and the permissions from the both hospitals. And sometimes you need to arrange a green corridor or a green channel to avoid the traffic, because these patients are on the verge of collapse. If you can arrange this green corridor or green channel, you can shift the patients immediately from the airport to your treating center. So, but most of the times, don't worry of all these permissions and then certificates. There are a lot many transporting companies that has came in through COVID or before COVID and after COVID. So, which are helping the doctors in managing all these permissions part, managing the travel part and all. As a physician, you can focus upon the patient, you can focus upon the patient safe initiation, and you can focus upon the safe transport. So, all these permission certificates will be taken care of those companies by those companies here. But you need to keep that in mind that while transporting a patient from a remote area to a particular area, the modality of transport, the permissions required, the certificates required, and if possible, a green corridor. So once the plan is done, you'll go to that particular place, you'll initiate the patient on ECMO. Once the patient stabilizes, you decide that you'll transport the patient through aerial route or an air ambulance to your particular place. So important things you need to remember is the oxygen. You need to calculate the duration, you need to calculate the distance and the duration requirements for the travel part. So based on that, your oxygen requirement will be there. So you need to have two oxygen cylinders at least, one for the ventilator part and one for the ECMO part, both. So you need to calculate the cylinders capacity and how much time they are going to cater for us. And the next thing is important is the power, whether the aircraft is having the power supply for the ECMO machine or not. There is no power supply, whether your machine is able to give adequate ECMO running time based upon their batteries. So you need to see, you need to check the ECMO machine's batteries also. There are so many machines and there are so many transports happening with an improper ECMO machines without a proper battery too, which is very dangerous. So even if you're transporting, you need to have a hand crank in your hand. So if the battery goes off, sometimes the flight might take longer duration of time. So the anticipated time might shoot up. So you might land up in having a power supply failure. In those situations, you have to do a hand crank, and hand crank is mandatory while transporting the patient, either by aerial route or ground ambulance. Logistics again. So again, how you are going to plan this flight transport here. So if you can see the chain of events from the ICU where you have initiated remotely, the patient should be shifted to the ambulance, and from the ambulance the patient should be shifted into the air ambulance or the flight ambulance, and from there again back to the ambulance, and from the ambulance to the receiving hospital or your hospital particularly. And don't forget the hand crank. Instances where people has transported the patients without hand crank, you're literally taking a risk on these guys. So you need to have a checklist for the flight transport also. As I'm quoting prior, so many companies do have the checklist, but even if they are doing it, you need to have your particular checklist in hand to prevent any last minute errors or last minute life threatening emergencies and all. So this is our team where we have initiated ECMO in 2017 in Orissa. So at that point of time, this is the whole team involved, and this is a particular ICU which is very congested. You can see there's a lot of congestion. You can see in the same picture there are three ICU beds. So we need to keep all the beds separately. You can see a lot of infusions going on for this patient, like sedation, paralyzing agent, and all those things. And this is particularly during this COVID time, 2019. Yeah, during this COVID time. So again, the initiation became much more cumbersome for us. But you have to plan accordingly for the safe initiation. The initiation part went on good, and then shifting the patient inside the ambulance. You need to have a proper space in the ambulance. You can see there's a transport monitor, there's a transport ventilator and infusion pumps here. And after the patient gets shifted inside the ambulance, the space for you to meddle is going to be pretty less. You can see hardly only two people can sit inside, and the third guy has to stand up. He cannot have the place to sit down and all. So we need to arrange the space also, apart from all the logistics which we have discussed, like the oxygen supply, power supply, and all. And then once we reach the tarmac, and then you can see here. So this yellow bag consists of lot many drugs. We have to load them prior to the transport part. So you need to keep the atropine, adrenaline, soda backup, all the drugs, all the emergency drugs. It's like a mini ICU. We need to carry along with you. The mini ICU crash cart you need to carry along with you, because during the transport anything might have happened. And don't forget to take the consent during the transport too. The consent is much more important part. So once you have reached the tarmac, you can see the ground tarmac on the airport here, and there is a flight waiting for us. And you can see in this particular picture, you can see there's a lot of wire. That means that there's a lot of blue line. That means the oxygen pipeline is there. I'll tell you why there is a lot much of requirement of oxygen pipeline. So once the patient comes out from the ambulance to the tarmac, you need to have an extra length of this oxygen pipeline. That's the reason why you need to have an extra 1/4 and 1/4 inch tubing. You call it as a 1/4 inch tubing for the supply of gas to the oxygen to the ECMO machine, and then for the supply of oxygen gas even to the ventilator part also. So this is how you transport the patient first onto a stretcher, and next comes is the most important or the most difficult task. So you need to monitor the patient always on this during all this transport. See, now you can see the ambulance aircraft here, and the height. The height is almost at around 5 or 4 feet height, and the entrance into this aircraft is pretty much narrow. You can see almost how many team members are really working hard to shift this patient inside the aircraft. So the patient is on the tarmac now, waiting for them, waiting to get shifted inside the aircraft. So you need to have, as I said, you need to have to change this oxygen pipeline from the ambulance into the aircraft or to a cylinder. So after that, once these things are done, the turning of the patient, see the aircraft entrance is pretty small entrance. You need to lift the patient as a whole, turn the patient on a regular basis inside this aircraft. There are new aircraft that are coming in which has avoided this problem by providing bigger doors, but these are the older generation aircrafts which we still use generally for the transport part. But you need to manage this kind of problems also during the transport. So once you're inside the aircraft, you can always see that you cannot move inside the air ambulance. It's small, a private jet with a capacity of hardly 6 members. You can see patient all sitting on one side. Patient berth is on one side, and you can see two persons sitting on the other side. If there's any problem, you're not supposed to do CPR. Also, the pilot will warn us saying that don't try to give any abnormal movements because a small flight you might be risking the life of others too. So once you're inside the flight, make sure every connections are properly fitted, make sure everything is properly done, and then the flight will get take off. And be prepared for extra oxygen supply source and extra power supply source. And you have to monitor every single step during the transport. Sorry. So we arrived at Hyderabad. The transport took us almost 1.5 hours. We arrived at Hyderabad. Again, the same problem. Shifting the patient out of the aircraft into the tarmac again, because you can see the door which does not fit properly. And again, it's the same plan. Once the patient comes out into the tarmac, shift the patient into the ambulance again, and the patient ultimately reaches our hospital. So this picture dates back to 2020 or 2019, where we have a safe distance transport of this patient for 2 hours. We have remote initiation was done for this patient and shifted the patient to our hospital in a safe zone. So with all the infusions, with all the ECMO machines, once the patient receives here, it's like just like receiving any ICU patient, all the vitals should be documented, go back to your previous flows and all those things. So this is how you need to properly plan for a remote ECMO initiation and transport to a particular centers. So remember guys, always preparation is the key to the success. In every single step, there might be a lot many complications which we anticipate or which we don't anticipate too. So all the anticipated problems, you need to have a solution for every anticipated problem, and you need to have a lot of experience to anticipate the problems too. And as I said earlier, without an exit strategy, don't try to jump into the ECMO and don't try to initiate the ECMO because everyone is doing surrounding you. So you need to have a proper preparation, you need to have a proper training, you need to have a proper skill set for initiating ECMOs and then trying to transport the ECMOs to a particular center. Hereby I'll stop my presentation. Thank you so much.